So if we have a suspect of COVID in the flu clinic or emergency or OPD, then we have to do the test of the patient. And if the test is positive, then we categorize the patient as mild, mild with risk factors, moderate, severe, and critical on the basis of this chart. Now, a mild patient is a patient who just has fever, cough, and minor symptoms of flu. These patients, as per the Indian guidelines, are eligible for home isolation. You don't have to admit them. But if the mild patient has risk factors like age more than 65, diabetes, hypertension, immunosuppression, transplant, these are the patients whom you would like to observe in the wards. Similarly, we have moderate, severe, and critical patients. Now, these are classified on the basis of increasing severity. Increasing severity means increasing requirement of oxygen, increasing chest X-ray worsening, and increasing involvement of other organs, which may gradually succumb to the COVID infection. So on the basis of these, we have moderate, severe, and critical. Mild and moderate patients can usually be managed in the wards, but as far as the severe and the critically ill patients are concerned, they have to be managed in the intensive care setting. So as a general guide, there are few indications for hospitalization for general interest. I would like to highlight these, that anybody with a COVID infection with a respiratory rate more than 24, saturation coming below 94, confused, drowsy, or a PP is not normal, it is low, or has a comorbidity including age more than 65, cardiovascular disease, diabetes, and chronic lung, liver, or kidney disease. These are the patients who may require hospitalization. Once you have the patient in the hospital, then we do the usual tests which are recommended. Plus, we have a risk stratification, which means we send a few set of parameters which tell us that if these parameters are on a higher level, the patient has a higher risk of developing complications and a higher risk of dying from the disease. These include D-dimers, ferritin, LDH, troponin, and ECG. So these are the basic tests which we do. X-ray is mandatory. You don't have to do a CT scan all the time unless you are suspecting some other illness. So as I told you, mild are the patients who have very mild symptoms. These are the patients as per Indian guidelines who can be monitored at home. And if they are admitted to a hospital because of comorbidity, or if they have a concomitant diabetes or immunosuppressive disease, then you just monitor these patients and they are discharged on the 12th day if the test of COVID is negative, as far as the Indian guidelines are concerned. If the test is not negative, we intend to keep them in the hospital and repeat the test every 2 days till the test is negative. Similarly, for patients who are mild but have risk factors, we try to maintain oxygenation. I told you 94% saturation is our basic standard, and we want to maintain oxygen at this level. Fluid may be required, and similarly, we give mild antitussives, antipyretics, and they may require sometimes inhaled therapy, but remember, we tend to avoid nebulization in these patients because there is a risk of aerosol dispersion. So we try to manage these patients with inhaler and a spacer as compared to a nebulizer. Now, these are the patients who may require treatment. As you are well aware that in India, we are using hydroxychloroquine, which is known as SCQ. It is given along with azithromycin. Azithromycin is an antibiotic, and it has been shown that if you combine both, then the killing of the virus is speeded up. Along with it, we are using oseltamivir. Now, this is a drug which we use for flu, H1N1 swine flu. Because in India, we have a mixed population, sometimes you can have a dual infection. You can have a COVID along with H1N1 infection. So we start empirically because both the clinical features are common. And once the H1N1 is negative, we stop the oseltamivir. Other drugs are available. If the patient is intolerant to SCQS, then we use a combination of lopinavir and ritonavir. And important thing is to monitor the toxicities. Please remember, you do not administer lopinavir-ritonavir combination with SCQS. So you are not combining the drugs. it is either SCQS or lopinavir ritonavir. Then for severe patients, now these are the patients which are most concerning. These are the patients who are in the ICU. These are the patients who have a high risk of complications. These are the patients who are the 5% of the lot which can die. We usually start with supportive care. We are using all the precautions to avoid aerosol dispersion, which means we don't want the patient to transmit infection to the healthcare providers. We are managing them in negative pressure rooms. We are using ventilators. Important thing to remember in these patients is that the standard drug which is recently recommended by the US FDA, remdesivir, we are using in these patients, but in some centers it is not available in India. So again, we are using a combination of hydroxychloroquine and azithromycin. If you are not able to use hydroxychloroquine or chloroquine, then we are using a combination of lopinavir, ritonavir in the given doses. Now, this combination is long available in the Indian setup. It is a drug which is used for HIV treatment also, but we are using this for the treatment. Chloroquine, a lot of debate is there, whether it is beneficial, whether it is not beneficial. I can tell you there is no conclusive evidence, but in vitro studies have shown, in vitro means studies which are conducted outside the human being, have shown that they reduce the viral shedding and hamper the step of viral replication. So as of today, we are using this drug as first line for patients who have COVID positivity. The problem with the chloroquine is that chloroquine is a cardiotoxic drug. Apart from being gastric intolerant, we have to do a baseline ECG. So ECG daily is a must. If there is a problem in the ECG, we measure a interval known as QTC interval. If it is high, then we stop hydroxychloroquine and tend to give the other medicine. Please remember, if you are combining hydroxychloroquine and azithromycin, which we are doing in our setups, we have to be very cautious because both of these agents can increase the QT interval, and you have to be very careful when you are using these drugs. But so far, I can tell you, they have been very safe. We have had few patients in which we had to discontinue the therapy, but generally it is very well tolerated. Azithromycin, as I told you, you should not use azithromycin alone. It is an add-on to the hydroxychloroquine because it has been shown that there is an increased reduction in the viral carriage if you are using the combination. Coming to lopinavir, ritonavir, I have told you if your patient is intolerant to hydroxychloroquine, there may be many who have complications. Then you have to use this combination of lopinavir, ritonavir in these patients. It is available in India also, and we have also tried this. Coming to remdesivir, the much talk about drug, and the US FDA approved it, and it has been recommended for compassionate use only because it's an expensive molecule. The only thing is that it has got hepatotoxicity, but the dosage is as given in this slide, and it has to be given for a total of 10 days, and it has been shown to be effective in reducing the severity and improving the patient faster. So this is the combination which is being evaluated. A lot of trials are going on, and the patients are already on this medicine. Oseltamivir, I told you, it is a H1N1 swine flu drug, but in India, because we have co-infections with COVID plus H1N1, so we are starting this drug empirically, and if the H1N1 test is negative, we are stopping this molecule after 24 hours if the test is negative. Then, as Dr. Hira mentioned, the cytokine storm, we know any inflammation in the body incites an immune response, a cytokine storm, and in COVID it has been seen that there is a cytokine storm which is modulated by T cells and inflammatory monocytes. These T cells and inflammatory monocytes, they gain access into the pulmonary circulation and they reduce the transfer of oxygen inside the lung. So that is the main problem with COVID. That's why the severity of the illness is so troubling that most of the patients are dying because of oxygen debt. Oxygen is not going inside the body. And this is the reason the cytokine storm is responsible for it. We have medicines to our armamentarium. One of the important ones is tocilizumab, which is an interleukin 6 inhibitor. Interleukin 6 is a major inflammatory mediator responsible for the problems in the lungs which are caused by cytokines. This drug has been shown to stop the action of interleukin 6 on the lungs. And the problem is hepatotoxicity, so we have to monitor liver functions, but it is being used in our severe patients and we are using it. Coming to hemoperfusion cartridge, now this is something which has been used in the past. Now these are, it is like a dialysis. You have to dialyze the patient and use a filter which is known as a hemoperfusion filter. This filter is made of a material which tends to absorb the cytokines and returns the blood which is purified or removed from cytokines to the patient. So it's like a dialysis with a filter which is removing the cytokines. There is a protocol for it, and I would not go into the details, but it has been used as a temporary measure to stabilize the hemodynamics and oxygenation of these patients. Another important and much discussed therapy, which is convalescent plasma. And we all know if a patient is recovering or has recovered from an illness, the patient tends to develop antibodies in the blood. So the thought came that why not transfuse these antibodies after matching into the patient who has the disease, and they may fasten or improve the patient faster. This therapy has been tried in the previous infections of Ebola and the MERS, SARS coronavirus, H1N1, all the epidemics and pandemics in the past. Plasma therapy has been tried with variable success. There were positive reports. So now in our severe category of patients who are deteriorating, who are not showing improvement in oxygenation despite usual therapy, we are using convalescent plasma. Now it is difficult to get plasma because you need a donor, you need a patient who has recovered. So the challenges are there, but we have seen enthusiasm in the public, and we are encouraging more and more plasma transfusion and trials to evaluate it, but initial results are showing a positive trend. Corticosteroids, a much asked question, do we use steroids? See, there is no major study, major trial in the previous epidemics of viral illnesses which have shown a positive response with steroids. So steroids should be reserved in patients with refractory hypoxemia and refractory shock, which means the patients who are severely ill of COVID, we are tending to use steroids, but otherwise we are not using them. Vitamin C, it has been shown in many studies that vitamin C has shown to reduce mortality in patients of these viral infections, and we are using a moderate dose of vitamin C, 1.5 gram every 6 hourly, and combining it with thiamine. And the cocktail has shown to improve the results in patients of these illnesses. But there is no high quality evidence, but till the time we have evidence, the little bit of evidence we have is sufficient enough to enable us to use it, and we are using vitamin C and thiamine combination in all our patients who are admitted into the hospital with this illness. Antibacterial therapy is not indicated. You don't need to give antibacterial antibiotics, but remember that viral infections can have a delayed superinfection. So a watchful eye, a daily assessment of the patient, worsening infiltrates, increasing oxygen requirement should guide you to add an antibacterial therapy, but it has to be individualized and it has to be an expert who can decide on this. There are other agents. I will not go into the details. So many drugs which are undergoing trials for use in COVID, and in many US centers, these trials in Italy also, the trials are undergoing of these medicines, and we have to wait for the results to come. Then important issue is coagulopathy, which means patients of COVID, we have seen they tend to clot. clot easily. And this is one of the major problems we are facing, that these patients are dying because their blood is clotting. Blood is clotting in the heart, causing heart attacks. Blood is clotting in the lungs, causing infarctions. So it is wise to do some tests which let you know that the patient has a tendency to clot. And on the basis of these tests, we add molecules which prevent clotting in the blood, which is known as thromboprophylaxis and anticoagulation. And we are using it in many patients, and we are doing D-dimer assay at the start of the treatment along with other coagulation markers to guide us. Ventilatory management, I will not go into the details because it's very expert driven, but let me tell you that we have expertise. The world knows that severe ARDS or patients who are in severe respiratory failure, we have got ventilatory management strategies to deal with these kind of patients, which include your high flow nasal cannulas, prone ventilation, and expert management of ventilator to enable them recover fast from the ventilator. ECMO, which means extracorporeal membrane oxygenation, which is again taking out blood from the body, oxygenating the blood and giving it back to the body. So you are artificially oxygenating the blood through this machine and returning back to the patient the oxygen-rich blood, because we know the lung is incapable of absorbing the oxygen. So this is a life-saving therapy in patients with severe form of ARDS and refractory cardiocirculatory shock. And this is reserved for very few patients. And let me tell you, so far we have not used it in any patients because either the patient was too sick to even, this requires a lot of training. You need to put cannulas. So we didn't get the time, but it is a therapy which is useful if you decide to use it early. So this is the end of my talk. And I thank you all once again.